Vikas, after the webinar, just give me a call on my personal mobile.
Yeah, sure.
Okay. Let's start with
3, 2, 1. We are live.
Hello, everyone, and a very warm welcome to today's session on restoring life in COVID-19 with Remdesivir. I'm Dr. Gulshan from Spirant. First of all, let me thank all of you for taking time out and being here today with us. We have with us here today Mr. Jasdeep Sood and Mr. Vikas Bansi from Jubilant Generics Limited. Mr. Jasdeep Singh Sood is the Senior Vice President and Head of Non-US Formulations Business of Jubilant Generics Limited. Mr. Vikas Bansi is the Vice President and Business Head for India Branded Pharmaceutical Business of Jubilant Generics Limited. We will be running a live question and answer session at the end of the webinar. So we have enabled our Ask a Question feature. So if you have any questions, you can just write them in there. I now invite Mr. Jasdeep Sood to take over the further session. Over to you, Mr. Sood.
Thank you, Dr. Gulshan. Good evening, good morning, based on which part of the world all of you are. Welcome to this global webinar on restoring life in COVID-19 with Remdesivir. Jubilant Generic is extremely proud to be part of these scientific initiatives. Just to give a brief on what Jubilant is, Jubilant Life Science Limited is an integrated global pharmaceutical and life science company. And we are engaged in pharmaceuticals, life science ingredients, and drug discovery and development solution businesses. Coming closer to Jubilant Pharma Limited is a company incorporated under the laws of Singapore and is a wholly owned subsidiary of Jubilant Life Science Limited. We are an integrated global pharmaceutical company, and we are engaged in manufacturing and supply and sales of APIs, solid dosage formulations, radiopharmaceuticals, allergy therapy products, and manufacturing of sterile injectables and non-sterile products through 6 US FDA approved manufacturing facilities, which are located in US, Canada, and India. And we also have a network of over 50 radio pharmacies in the US. The company has a team of 5,200 multicultural people across the globe and is committed to deliver value to its customers who are spread across more than 75 countries through its quality products and scientific services. This webinar being part of one of those initiatives. With this, I will pass on to Vikas to introduce our eminent speakers for the day and take this session forward.
Thank you. It is indeed my privilege and pleasure to be here with all of you. And good morning, good evening, and welcome to each one of you once again. Jubilant Generics Limited has recently launched Remdesivir, which is a potential therapy for COVID-19. And we welcome you all for this scientific symposium. I would like to take this opportunity to introduce our 2 esteemed speakers for the symposium today, starting with Dr. Robert Grossberg, who's an associate professor of medicine at Albert Einstein College of Medicine and an infectious disease specialist at Montefiore Health System. He has over 24 years of experience in the medical field. He graduated from Brown Medical School in 1996, and he is at present an investigator in the Remdesivir trial and shall be sharing his valuable experience with the audience today. Our second speaker for the day is Dr. Subhal Dixit, Director Critical Care at Sanjeevan Hospital, Pune, an immediate past president of Indian Society of Critical Care Medicines, an immediate past chancellor of Indian College of Critical Care Medicines. He has been a faculty in various national and ESICM international conferences and author of various critical care books. He would also be sharing with us today his experience with the use of Remdesivir and COVID-19 patients. We welcome you all and both our esteemed speakers once again. And without any further ado, would like to invite Dr. Grossberg to please take over. Dr. Grossberg, over to you.
Thank you very much, and thank you for tuning in. I'm really happy to be invited to share share some of this data on this topic and my experience with it. And I really appreciate all of your efforts in your countries and what this whole world is going through. It's nice to share this in a really global way. Let me just, okay. So just by way of introduction, I think the listeners are all aware COVID-19 is an acute respiratory illness caused by a novel human coronavirus, which has been named SARS-CoV-2, also called the COVID-19 virus, the cause of the syndrome or disease COVID-19. So SARS-CoV-2 is a positive sense single-stranded RNA virus belonging to the genus of beta coronavirus. It has significant mortality, particularly in people over 60, although most people infected with SARS-CoV-2 have either mild illness or asymptomatic illness. Infected patients generally present with mild upper respiratory infection symptoms, similar to the common cold, which can be caused by other coronaviruses at the early stage and may be afebrile on the first 1 to 2 days. Severe presentations have been associated with underlying comorbidities, such as hypertension, diabetes, coronary heart disease, chronic obstructive pulmonary disease, among others. And there's emerging evidence that obesity or a high body mass index is also an important risk factor for severe disease. COVID-19 is transmitted primarily, we believe, by droplet transmission, so inhalation of relatively large airborne droplets. There's also transmission via hand-to-hand contact or via fomites. So if an infected individual touches either a person or an object that has coronavirus on it and then touches their face in particular, their nose or mouth or eyes, some mucosal surface, that would be another mode of transmission. And in general, close contact with infected persons. There is increasing evidence and controversy around the role of aerosols, which would be small droplets, which can remain in the air for hours, as opposed to droplets which remain in the air for seconds to minutes. And there clearly is a role for aerosol transmission as well, but the extent of that remains somewhat controversial. So the diagnosis of COVID-19. So the COVID-19 treatment guidelines panel and other guidelines panels recommend molecular or antigen testing for SARS-CoV-2. And this testing should be performed in all persons with the syndrome consistent with COVID-19 and in people with known high-risk exposures to SARS-CoV-2. Currently, the most commonly used diagnostic test is a real-time reverse transcriptase PCR assay to detect viral RNA in respiratory samples. There are other modalities for testing, including other PCR tests and antigen tests, but most commonly we're using the real-time PCR. And we're using nasopharyngeal samples most commonly, although oropharyngeal swabs can be used as well. The yield is increased if you use both, actually. So in my institution, most patients are getting both, or many patients are getting both. In fact, sometimes with the same swab, starting with the oropharyngeal swab and then just using the same swab in the nares. Another method of diagnosis, if there's a high clinical suspicion, bilateral ground glass opacities seen on a chest CT scan can be used to confirm infection with COVID-19, at least in areas where we have access to molecular testing. This last means of diagnosis is not relied on as heavily as the molecular tests. So shifting into the prevention and treatment methods for COVID-19. So I think it's worth just reviewing the life cycle of the SARS-CoV-2 virus and where drug targets might exist. So the virus enters the cell via two receptors, the ACE2 receptor and the TMPRSS S2 receptor. So those have been considered potential targets to inhibit viral entry. And then once in the cell, it uncoats, and this single strand of RNA is processed and then transcribed and translated into proteins, and then the daughter virus is released back into the plasma. So you can see here on this diagram, which is from an article in JAMA, potential targets for drug activity. The other approach for treating COVID-19 has been to address the inflammatory response because it appears that as much as the virus itself may be causing damage, a dysregulated immune response and at times hyperactive immune response may be equally as important in causing morbidity and mortality. So this diagram from Science shows how coronavirus triggers an immune response in various lymphocytes, resulting in the release of cytokines, particularly IL-6, but others appear to be important as well. And this cascade of inflammation presents other targets for immunomodulatory agents, which are becoming increasingly important to consider in treatment, and there's emerging data about many of these. So what are the treatment options available for COVID-19? This is a story really of repurposed drugs. So because of the speed at which this disease has emerged from the depths of China somewhere, whether it was from a bat or via another zoonotic source, things took off very quickly. So in order to find drugs that might have activity quickly, the approach has been generally to try to repurpose existing available drugs. So among those were the antimalarial agents, chloroquine and hydroxychloroquine, which are relatively inexpensive, widely available. There's vast clinical experience using these for other diseases. So chloroquine, an antimalarial drug, an autoimmune disease drug, is thought to block virus infection by increasing the endosomal pH required for that step of virus and cell fusion, and then interferes with the glycosylation of cellular receptors of SARS-CoV-2. And initially widely used in China and some of the earlier sites where this pandemic started. And hydroxychloroquine, the sister drug to chloroquine, it had been used in the previous SARS outbreak. It was observed to have strong in vitro activity against SARS-CoV-2 infected cells. It also has an effect of suppressing some cytokines, which is why it may have use in lupus and some other autoimmune diseases. So the story with these drugs, at least from most people's perspective, is that they don't work and that they have an unacceptable degree of toxicity, especially in seriously ill individuals. So that's, I think, there's been a lot of political controversy in the United States, where I am, about hydroxychloroquine. So this has taken on a life of its own, but from a scientific perspective, I think there's ample data that this drug doesn't work, or these drugs do not work. There are a number of other, again, repurposed drugs that have been tried. Nitazoxanide is an anti-parasitic drug with antiviral properties and inhibits a number of respiratory viruses in culture. It's being looked at. I don't think there's good data either way yet. Ivermectin is another anti-parasitic drug with antiviral activities. Again, not a lot of promising data to suggest that this is going to work either. And azithromycin, an antibacterial agent commonly used for respiratory infections and mycobacterial infections, STIs, has anti-inflammatory effects. This has been well known, including the induction of interferon stimulation and enhanced neutrophil activation, and tamping down of some pro-inflammatory cytokines like IL-6 and IL-8. So it has been used for its anti-inflammatory process in other diseases like cystic fibrosis and as an adjunct to treatment of certain infections. However, and it's been examined in combination with the anti-malarials, but there really is no promising evidence that this is going to be an effective strategy. Immune-based therapy. So this is the use of human blood-derived products obtained from individuals who have recovered with SARS-CoV-2. So in general, this is also known as convalescent plasma. There was a lot of excitement before there was really any effective antiviral or anti-inflammatory approach. There was a lot of excitement about collecting plasma from COVID-19 survivors and administering that to patients. So there is some experience with this and some reported data from compassionate use type protocols and limited randomized trials, one reported recently from China. But nevertheless, there really isn't a good randomized placebo-controlled large trial that says this approach works. That is underway. I know the NIH is sponsoring such a trial. So we should have more data on the effectiveness of convalescent plasma, I think, in the next few months. Dexamethasone or equivalent steroids. So these are now recommended for the treatment of patients who are mechanically ventilated or require supplemental oxygen, but not yet mechanically ventilated. So this is a widely available, relatively inexpensive drug that has been demonstrated to have benefit in sicker patients. So this has become, at least in the United States, the standard part of the standard of care for these types of patients. And then the IL-6 inhibitors, sarilumab and tocilizumab, there's insufficient data. There may be a niche for some of these drugs in very sick patients. Identifying the right patient for these types of drugs, I think, remains a challenge, and potentially these drugs might be more harmful in less ill patients, but we're still sorting that out, I think. Similarly, for the JAK inhibitors, baricitinib and others, these target yet another part of this IL-6 cascade and may block the cellular entry of SARS-CoV-2 into the lungs. Again, where these fit in the treatment and which patients might benefit the most we don't know yet. And then lopinavir, ritonavir, another repurposed drug. This one used a protease inhibitor that's widely used, or at least was in HIV. It has good in vitro activity against SARS-CoV-2, but it did not demonstrate benefit in a number of different trials. So this has fallen out of favor, at least in most guidelines writing panels. So protease inhibitors don't seem to be the right approach. So this brings us to the star of the show, I guess, remdesivir. So remdesivir, another repurposed drug sitting on the shelf at Gilead after it didn't work for hepatitis C, which is what it was developed for, and had been tried for Ebola virus. There was some human experience using it for Ebola virus. And there was an observation that it was active against coronaviruses. So it achieved this second life. So COVID-19 treatment guidelines panel now recommends the antiviral agent remdesivir for the treatment of COVID-19 in hospitalized patients with an oxygen saturation of less than or equal to 94% on room air, or those who require supplemental oxygen. So remdesivir, it's a nucleoside analog and adenosine analog. It has broad spectrum antiviral effects, like I said, against a number of different viruses, including Ebola and SARS-CoV-1 and MERS-CoV, these other coronaviruses. And it delivers this monophosphate nucleoside analog into the cell and then inhibits the RNA dependent RNA polymerase. So this enzyme, viral enzyme that is involved in replicating the viral RNA is inhibited by this drug, causing termination of the RNA chain and arresting viral replication. So I'll share with you some of the evidence regarding the potential benefit of remdesivir. So the first study we'll talk about is the study that I participated in with at my institution, the Adaptive Clinical Treatment Trial, or ACT-1. This is a study funded by the NIH, multi-centered international study, and it's a placebo-controlled, randomized, double-blinded study. So the study enrolled over 1,000 patients, and these were randomized 1-to-1 to receive either remdesivir for up to 10 days or placebo. The main clinical outcomes were time to recovery, defined either by discharge or clinical improvement. And the results, which have been widely publicized, were that patients who received remdesivir had a median recovery time of 11 days as compared with 15 days in those who received placebo. And this was a statistically significant finding. There were differences in which patients benefited the most. So patients with a baseline ordinal score of 5, these were patients who were on supplemental oxygen, but generally not mechanically ventilated. So kind of moderately to severe ill, but not critically ill. The rate ratio for recovery was the highest, or 1.47. So that suggested that there's this sweet spot for who might benefit from remdesivir. Patients with a baseline score of 4 and those with 6 also likely received benefit, but there was less. This was not statistically significant. And in terms of mortality, looking at all patients, they were unable to demonstrate a statistically significant mortality benefit with remdesivir. The deaths were 7.1 versus 11.9, which looks good. 7 versus 12, but did not achieve statistical significance. So this figure, I think, displays this well. So this is looking at the days that in the study, and then on the y-axis, the proportion who recovered from their illness. So in the top left or rectangle A, this is all patients. So you can see that the proportion recovering is higher throughout in the patients who received remdesivir. And then in patients in the box below that, it's rectangle C, you can see the gap between the remdesivir and the placebo group is the widest. So you can see this might be the patient group, patients receiving oxygen, that may benefit the most. And then in the bottom right, in rectangle D, these are the patients who are either on high flow oxygen or mechanically ventilated. And these are patients where the observed benefit, there was no observed benefit. So you can see the curves there are more or less congruent. So not clearly beneficial in critically ill patients, but most beneficial in patients who are moderately to severely ill. This is another way of looking at this, and I think I highlighted some of these. So this is just looking at this overall finding of time to recovery, statistically significant, 11 days for placebo, 11 days for remdesivir versus 15 for placebo. And then looking at mortality, overall didn't show a benefit. But if you look at the patients with this ordinal scale of 5, so moderately to severely ill, not critically ill, that looked pretty good there. That's 4 deaths in the remdesivir group versus 19 in the placebo group. So in that group, there was a statistically significant benefit. So to conclude, this section, remdesivir was superior to placebo in shortening the time to recovery in adults with COVID-19 and evidence of lower respiratory tract infection. There have been a number of other trials using remdesivir. So the SIMPLE trial, there's a few SIMPLE trials. These are funded by Gilead, looked at 5 versus 10 days in patients with severe COVID-19. So this was a randomized open label trial. And these patients, same criteria as the ACT study. So they had to have a O2 sat of 94% or less. And they were randomized 1-to-1 to receive either 5 or 10 days of remdesivir. So no placebo here. It's just 5 versus 10. 397 patients were randomized and received, again, either 5 or about 10 days. Patients who were discharged didn't receive any more treatment, so the median duration of treatment in the 10-day group was actually 9 days because some patients got better and went home. And for just a fluke of the randomization, the 10-day group actually started out with worse clinical status than those assigned to the 5-day group, so there's some limitation there. There were some adverse events, but generally mild. This drug seems to be generally well tolerated. And again, I highlighted some things here. So this is looking at the 5-day group versus the 10-day group. You can see the median time to clinical improvement, 10 versus 11. Median time to recovery, 10 versus 11. So no statistically significant difference between 5 days of treatment or 10 days of treatment. So the bottom line is 5 is probably enough, except maybe in these patients here. So you can see here, patients on ambient air and low flow oxygen on the right here. The 5-day group and the 10-day group, just looking with your naked eye here, look very similar. If you look at the invasive mechanical ventilation, the first 2 sets of bars all the way to the left, you can see that death was higher in the 5-day group versus the 10-day group. So that's led to the suggestion that patients who are intubated may benefit from a 10-day course as opposed to a 5-day course. Everyone else probably can just get 5 days of remdesivir, and that's fine. So in conclusion, the trial did not show a significant difference in efficacy between a 5-day and a 10-day course of intravenous remdesivir in patients with severe COVID-19 due to SARS-CoV-2 who did not require mechanical ventilation at baseline. And patients who progress to mechanical ventilation may benefit from 10 days of remdesivir. That's the strategy we're using in my institution. Generally, people are getting 5 days unless they are on mechanical ventilation. We may extend it to 10. So there have been subsequent simple trials from Gilead and combinations of trials. This is from a announcement from Gilead about 2 randomized open label multi-center phase 3 clinical trials. This includes the trial that I just spoke about, plus another one of these simple trials. 5 days of remdesivir in the treatment group were 65% more likely to have clinical improvement at day 11 compared with those in the standard of care. I'm sorry, this is a different simple trial than the one I just spoke of. So this study looked at hospitalized patients with evidence of COVID-19 infection and pneumonia. And these were randomized to 1:1:1 to 5 days versus 10 days versus standard of care. So no placebo, it's open label, but one of the arms did not receive remdesivir. And this just looks similar to the other study. There really were not significant differences in the 5 days versus the 10 days with treatment of with remdesivir. And then there have been subsequent analyses of these phase 3 simple trials. So this was a comparative pre-planned analysis of the simple severe trial compared to a real-world retrospective cohort. So there are limitations there in the way this is analyzed, but in patients with severe COVID-19, it showed that remdesivir was associated with significant improvement in clinical recovery, along with a 62% reduction in the risk of mortality compared with standard of care. So I think it's hard to take too much from that because of the way this data is being analyzed, but suggests there's promise here on the mortality benefit as well. So 74% of remdesivir patients recovered by day 14 versus 59% receiving the standard of care. The mortality rate for patients with remdesivir was 7.6 versus 12.5 among those not taking remdesivir. And this did achieve statistical significance. And then subgroup analyses showed that across different racial and ethnic subgroups in the US, traditionally marginalized racial or ethnic groups treated with remdesivir in this study experienced similar clinical outcomes as the overall population. So this is of great interest in the United States, where there's been a reckoning a little bit in the last few months about many things about racism and our biases in this country, particularly in healthcare and in clinical trials, and in what happens when pandemics occur. So it's important to note that remdesivir works across all racial and ethnic subgroups. There's also been in the pediatric population and the pregnant population through the company's compassionate use program. So it worked well in the small number of patients that were reported from these populations. So the results of this comparative analysis add to the previously published studies I reported that randomized double-blind placebo-controlled studies in hospitalized patients with COVID-19 showed a shortened time to recovery by an average of 4 days as compared to placebo. So that's the finding from the Act 1 trial, probably the best designed of these trials, and subsequently supported by other trials that I talked about. So why Remdesivir? So Remdesivir, as I said, resulted in a shortened time to recovery from 15 days to 11 days versus placebo. And 5 days appears to be enough. A 10-day course improved patient outcomes when compared with other drugs, but 10 days probably now reserved for patients who are intubated, at least in the United States. There's also studies that have shown remdesivir was superior to combined interferon beta plus ropinavir ritonavir in a mouse model. And in other animal model studies, early administration of remdesivir showed a significant reduction in viral load in bronchial alveolar lavage compared to the vehicle, and also decreased pulmonary infiltrates in SARS-CoV-2 infection of rhesus macaques. So other supportive data for why this drug might be beneficial. It's found to be a potent inhibitor of SARS-CoV-2 replication in human nasal and bronchial airway epithelial cells, so probably reduces transmission and potentially might have a role for prophylaxis even. Its use has really been spurred by the fact that there really hasn't been any other effective antiviral approach to SARS-CoV-2. And it's been found mostly to be beneficial in patients receiving supplemental oxygen, but not yet intubated or in critical condition. So I just wanted to mention, so what's on the horizon? So the ACT trial funded by the NIH was meant to be an adaptive trial. So it's moved into its next phases. So the ACT 2 trial is fully enrolled and actually in its data collection phase, which looked at remdesivir. All patients got remdesivir and then were randomized to receive the JAK inhibitor, either baricitinib versus placebo. So we'll have data on that study probably in the next month or so, maybe less. And the ACT 3 study, which began enrolling this week actually, we're awaiting activation at our site, is looking at remdesivir versus interferon beta 1A or Rebif, which is a drug that's been used in multiple sclerosis and some other immune mediated diseases versus placebo. That's given subcutaneously. So still looking for the silver bullets, I guess, if we're looking at combinations, but a lot of progress has been made. And I thank you for your attention. And again, I thank the organizers for inviting me. It's been a real honor.
Yeah, thank you, Robert, for an excellent presentation and for taking across all the trials, right from the first initial trial, from the preliminary report, right to what is there onto the horizon. So it was an excellent talk. We have got certain questions for you, which has come into the chat box and which we'd like to discuss it along with you. So the first important questions that we'll also be sharing is there any specific patients or any patient with symptoms of COVID would you specifically choose for giving remdesivir? We know that the patient has got upper respiratory tract infections. The patient can also present from apart from respiratory infections with encephalitis or with GIT symptoms. So is there any specific symptoms which you look for before initiating remdesivir on the basis of symptoms only?
So, I mean, the drug has really been shown to be beneficial in the setting of pneumonia. Whether or not it has any benefit in patients with other COVID syndromes like encephalopathy or myocarditis or some of these other organ systems is unknown. So we're really using it in patients with symptoms of pneumonia, particularly shortness of breath, cough. Patients who are admitted with just fever and other syndromes, but don't have evidence of pneumonia, we have not been giving remdesivir per the guidelines. We really have to have some degree of hypoxia, need for supplemental oxygen, etc.
Yeah, I completely agree with you, Robert, on this part that there has to be a pneumonia with hypoxemia for initiation of it. There's also been discussion that there's been different mortalities into different parts of the world. India currently stands with about 35,000, 38,000. US had a different mortality. The European countries, Spain had different mortalities. So does this mean that the different numbers of mortalities is related to the change the virus has undergone a mutation? And if the mutation has occurred, whether that is a thing which is worrisome as far as the mortality is concerned. So, in short, is the virus undergone a mutation and does it affect the severity of the disease?
I don't know the answer to that. I don't think anyone does, but it is very interesting. The virus has undergone mutations. What those mutations are doing, I don't think is well understood. It might have an effect on mortality. Some of the mortality differences among countries, is probably due to other factors like comorbidities and the availability of medical care, etc. And I can speak for the phenomenon in the United States has been interesting. In New York, where I am, we had a major surge and very high mortality. Now we have surges happening in other parts of the country that appear to be just as intense in terms of the epidemiology, but the mortality rate is much lower. So whether that's driven by some change in the virus or if it's that younger people are getting infected now because older people are being more self-protective, or because we're using a lot more dexamethasone and remdesivir and other things, I think all that is not understood. So the mortality of this virus has been a moving target. I don't think anyone has really pinned that down, but it does seem to vary. I don't think it's all
Now, just
driven by.
sticking here to the point, like there's also been the Lancet study which has come up with dexamethasone of 6 milligrams for OD for 10 days, either IV or oral. And if you compare it with methylprednisolone 1 milligram per day, twice a day, they even said that there have been also discussions that methylprednisolone has got a more penetration into the lungs as compared to dexamethasone, because even into the respiratory asthma GINA 8 guidelines, they said that methylprednisolone is the drug of choice, especially in acute severe asthmas. From that basis, the penetration of methylprednisolone is better into the lungs as compared to dexamethasone when compared with. So, which is the better combination when you use it with remdesivir, dexamethasone or methylprednisolone?
Uh,
It's a
I
very
don't.
difficult question to
We have
answer,
to figure
Robert. I
that
know.
out. I know now in our institution we're using a lot of dexamethasone, but that's based on the one study. I don't. We used a lot of methylprednisolone before because that's usually what we use in patients with respiratory issues. But yeah, I don't know.
So that's what, okay. So apart from the solidarity trial, which the WHO has planned, they're also comparing it with different kind of drugs. So where does Remdesivir stand at this minute of time into the solidarity trial?
I think for now it stands, in front. I think it's the antiviral drug for which there is the most data, and it's the availability is somewhat limited, but I think its limitations are it's not like patients get remdesivir and then they stand up and walk out of the hospital, the benefit is pretty modest. If we look at 15 days versus 11 days, it's 4 days, but still people are taking 11 days to recover. So it's a modest benefit. So we need something better, either combination or something for treating patients earlier with mild disease.
Okay, so I go with you. And another question which I'd like to couple them together, especially in ski, we know that usually about 5 days, 7 days, we are dealing with a cytokine storm, which the COVID patients do have, where it's precipitated by hypoxemia because of a release of a large amount of cytokines where IL-6 plays a big role. Now, remdesivir itself is an antiviral. So if you initiate in remdesivir at the time of cytokine storm, is it better? Or remdesivir is better during the initial phases of viremia? That is another question what we have got. So whether you should initiate it when you have a cytokine storm, or whether you should initiate it where there is initial viremia pre-cytokine storm.
So, we might hypothesize that it's better to initiate before this so-called cytokine storm. I mean, the term cytokine storm is used a lot. It's very vague. What is really happening there varies across patients. Patients without this sort of cytokine storm syndrome develop fever and feel ill and all of that. So I don't know that all of that is cytokine storm. It may just be the normal response to the virus. There are patients who develop this really severe inflammatory state where they have very high markers of inflammation, etc. So there's a lot unknown there about cytokine storm and what all that is and who's getting it. And so I think remdesivir, the data, at least from the ACT trial, was that the benefit was clearly and mostly seen in patients who required oxygen. So patients who are mildly ill, most of those patients are going to get better without treatment. So I don't think it makes that much sense to treat mildly ill patients with, an expensive intravenous drug.
Yeah, and those patients now who start needing oxygen, especially when the D dimers are on the higher side, would you continue them on dexamethasone? And what is the exact, and these patients also would be continued on a low molecular weight heparin, especially because of the antithrombotic properties of COVID. So that's another question onto the chat box. So I think it's quite simple, just the markers or any patients who is senior above the age of 60 with diabetes having high markers should be kept on low molecular weight heparin, especially for prevention of the further complications. What is your opinion onto that?
Yeah, I think I would. We use CRP and D-dimer as mostly as indications to use steroids, along with their oxygen status, as indications to start steroids and anticoagulation, the D-dimer.
Okay. Then we know that there is hepatic dysfunctions. Did you come across with any hematological manifestations after use of remdesivir? Hepatic dysfunction is quite well known. So any thrombocytopenia or any other kind of eosinophilia, did you come across with the use of remdesivir?
No, we have not that I know of. We've had anemia, but a lot of that was driven by other things, most likely. So no, we did not see a lot of hematologic, or have not seen a lot of hematologic abnormalities.
And how do you titrate? We know that it cannot be used below a creat clearance of 30, but especially we have a CRF patient who is on immunosuppression post-transplant, he gets a COVID. And how will be your strategies to handle the doses into these kind of patients? If the patient is on dialysis and if the patient is not on dialysis, the two subsets.
We haven't been using remdesivir in patients on dialysis or in patients with GFRs less than 30 in general. 30. So in the study, if patients developed acute kidney injury and their GFR went below 30, we held the drug and resumed it when their renal function improved. But we haven't used it in people with renal dysfunction in general.
what is your thought? Like all antibiotics, we modify it as per the Cockcroft's equation. So what is your thoughts on giving half a dose of remdesivir into these kind of renal failure patients or onto those patients who are on dialysis? It's just a thought. What
Mhm.
is your thought onto this?
I don't know enough about the pharmacokinetics. Maybe in the next talk there'll be
Yeah,
more
I will
about
be
that.
covering up. So I wanted
Yeah.
to
So
know your opinion on that. Because
we
since you'll
haven't.
be leaving after this, I thought I might as well take your opinion.
Yeah, I don't. I defer. I defer to you. So I don't have I don't have experience with that. I'm not familiar enough with the PK, etc.
PKPDs. Yeah. So, because these are the questions what we had for Robert here onto the chat box. I thank Robert for an excellent presentation and taking us through to the different studies and the trials precisely and concisely and giving us the analysis of all the trials and the American experience and guidelines as far as the use of remdesivir is concerned. So I thank Robert for an excellent presentation and hope to see you soon sometime in the future. Till then, stay safe and take care. Vikas,
Thank you
any
very much.
comments? Yeah, thank
So
you.
thank you, Dr. Robert. Thank you. And Dr. Dixit, we now move on over to your presentation to
Yeah,
get Indian perspective on, on what we should look forward to when it comes to
yeah,
remdesivir and COVID-19 in general. So over to you, Dr. Dixit.
yeah. So just let me erase that. Yeah,
Sure.
yeah. Can you see the slide? Yeah.
Yes.
Thank Jubilin for inviting me to give today's talk. I'll be talking about the Indian use for remdesivir and also be talking about the various pharmacokinetics and the various drug interactions in case if remdesivir has it. And in the end, a few slides, I'll be sharing a few data from my hospital and how the effects of remdesivir, what we are getting at this minute of time. We know that India is at the peak. We have got approximately 19.5 lakhs people who have been affected with about 39 to 40,000 deaths at the time as of when I am talking. And the novel coronavirus, we have gone through, we have got different discussions, different from the ICMR to the WHO, and we have got various drugs which were taken into consideration, right from chloroquine to hydroxychloroquine to the anti-HIV, the lopinavir, the ritonavir, till various other drugs are still into the pipeline with ivermectin. We have got recent other drugs as far as the Mycobacterium W, which has also been considered, till the recent antivirals where remdesivir, whereas initially was also being discussed by WHO as well as ICMR. And we will be focusing our discussions mainly on to remdesivir for the remaining part of the talk for which we are here today. There have been also discussions where Robert has also covered onto azithromycin. There have been discussions onto tocilizumab, which is a potent interleukin 6 inhibitor, along with itolizumab. We have also got other JAK inhibitors, which are also considerations till the Solidarity and the ICMR launched trials into different parts of the country, where we have got convalescent plasma, which is also being considered upon approval by the ICMR and with a prior permission from ICMR. But we will be focusing our talk mainly onto remdesivir aspect today. The ICMR and the Ministry of Health has classified COVID in India into three different categories as mild, moderate, and severe, depending upon the symptoms. The mild patients are mainly handled into the COVID care centers or into the quarantine centers, while the moderate and the severe are the ones which we'll be taking into consideration and discussing it today, who are mainly admitted to the COVID designated center or the COVID designated hospitals. These are the patients who have got pneumonia. These are the patients who have got pneumonia with respiratory distress. They may require oxygen. They may require high flow nasal oxygen. They may require oxygen with the help of non-invasive mechanical ventilations. Or in severe patients, these are the patients who will be intubated and mechanical ventilated. And these patients are the ones who will be having complications of multiple organ failure. The COVID panel in the form of D-dimer, CRP, ferritin will be on the higher side. And these are also the patients where you'll be getting maximum incidences of thrombotic disorders or other complications of COVID or secondary complications of COVID with multiple organ dysfunctions which are there. So we won't go into the aspects of ventilatory management or oxygen management, and we'll be sticking mainly into the aspects of the drug management protocols for COVID-19 and especially giving interest to remdesivir. So the severe patients, even the ICMR and the Ministry of Health has approved it, that Remdesivir has been approved for use in India for treatment of moderate to severe kind of diseases, especially where they are proven. And we will see the timing, what is very important, and how Remdesivir should be initiated. The clinical trials which have been studied, the remdesivir is, as I told you, it's a novel nucleotide analog. It has got activity against acute severe respiratory coronavirus in vitro. It's mainly the virus which is mainly which is mainly consolidated into the upper respiratory tracts and also into the respiratory tracts or into the lower respiratory tract. And various other drugs as far as antivirals, anti-inflammatory, malarial drug, TB, leprosy, and other immunomodulators have also been studied and are being tested, and various other drugs are also in the pipeline for the treatment of novel coronavirus, and which recently also another 2 or 3 drugs are still in the pipeline from ICMR for approval for treatment of coronavirus. But let us stick today to remdesivir. The first study, which also Robert has also covered, where he was also a part of it, and this study was the preliminary report study which came up and which was published in NEGM, and which Dr. Bijal was the primary author. They mainly conducted the studies with about 1,063 patients, and they compared it with placebo, and they definitely found that remdesivir was superior to placebo in shortening the time of recovery into the adult patients, where they found that in the group where remdesivir was used, 11 days was the recovery period, as compared to 15 days was the recovery period into the group where a placebo was used. And even as far as the mortality was concerned, they found that especially into the moderate kind of group, where definitely the mortality was only about into 4 patients as compared to 19 patients into the group where where the patients had severe kind of disease. And definitely, therefore, in India, the indications of using remdesivir has been approved for moderate to severe kind of COVID-19 patients, while in the United States, the FDA has issued an emergency use of authorizations for remdesivir for hospitalized patients in children as well as in adults with severe COVID patients, those who have got a saturation of below 94% on room air, those who require supplemental oxygen, mechanical ventilation, high flow ventilation, or in the form of non-invasive ventilations, or those patients who require ECMO. But most importantly, the selection of the patient as well as the timing of the disease and the timing of initiation is very important, and it should be given early in the course of the disease, which has also been seen from certain trials. The availability of the drug, yes, is now available in India through the ICMR, and initially it was now available as a part of the solidarity trial approved by the ICMR. But now ICMR has been kind enough, and FDA as well as the drug controllers have been kind enough, and now it's been available freely into the Indian market, and it's easily available. It's available in the form of powder, which is a lyophilized powder, and reconstitution is done with the help of 0.9 ml of saline, and it should be done prior to administration. And the active ingredients of it, as you can see here, is mainly the sulfobutyl cyclodextrin, sodium salt, and water for injections. And that is the most important, and may include hypochloric acid and hypochlorous acid for adjustments of the pH. Remember, you should remember that cyclodextrin is one of the component which is the part of it, and that's the reason why in renal failure you must use it very judiciously, and that cannot be used because it's mainly excreted by the kidneys, the cyclodextrin, and that's a very important part. This is mainly available as 5 milligrams per injections. You are supposed to dilute it, and you should give it as a part of infusion over 1 hour. Mind you, please use a syringe pumps at the time whenever you are giving it, or in the form of a delivery system where a proper delivery or proper infusion is being done after proper dilution with 0.9% of saline. The most important ingredient is remdesivir is an adenosine nucleotide prodrug, and this is metabolized pharmacologically to the active component of nucleoside triphosphate, and this is being distributed into the different cells with maximum amount of concentrations into the upper respiratory tract as well as into the lungs. That's most important. And remdesivir triphosphate acts as an adenosine triphosphate analog, and this competes with the incorporations of the RNA chains by the SARS coronavirus RNA dependent RNA polymerase, and thus resulting in delayed chain transmission during the viral applications. So more important, excretion is via the kidneys, urine in 74%, and the feces is about 18%. And most important, the mechanism of action is the delayed chain transmission during the viral application. That is, it definitely reduces the viral load by acting at the various levels, especially into the respiratory tract, and by the pharmacologically active agent. The optimal use and the duration, we said that yes, there has to be definite evidence of pneumonia. The optimum duration of treatment is exactly unknown. There we have also got studies where it has been compared, which I will show you in due course of my talk. But definitely where it has been studied for 5 days or 7 days or 10 days, even for patients requiring invasive mechanical ventilations or those who are on ECMO or those patients, yes, the recommended form of invasive mechanical ventilations or those who are very critically ill, it should be given for 10 days. But those patients who are not requiring any invasive mechanical ventilations or ECMO, it is proven that the total duration of therapy should be limited to 5 days. And if the patient does not demonstrate a clinical improvement day, then the treatment may be extended to an additional 5 days for a total duration of 10 days. But mind you, the patient needs to be onto ECMO or the patient needs to be onto invasive mechanical ventilation. And the infusion should be given over 1 hour, and you have to flush the line with 30 ml of normal saline after remdesivir infusion. The reason for flushing it, they should not have any residual amount of drug to remain into the saline, into the catheter mount or into the delivery system, so that the full concentration of drug gets delivered to the patients. And that's the reason of why flush, and this has also been recommended by the FDA. As I told you, the paper which was published in NEGM for 5 days versus 10 days, this was done by Goldman. Here they found that in patients who were severe COVID who are not requiring mechanical ventilation, the trial did not show any significant difference between a 5-day course and a 10-day course of remdesivir for delivery. But these patients also looked into consideration the death of the patients. The death of the patients was almost, it was less into the group where 5 days was given. But apart from that, into the patients, they also took into consideration the clinical improvement of the patient. The clinical improvement was better into the 5-day group as compared to into the 10-day group. They also looked into the recovery of patients. The percentage of people almost recovery was in about 32 as compared to 27 into the 10-day group. And the modified recovery was also better into the group of 5 days as compared to the 10 days. And the mortality rate, if you also consider into the moderate group, the mortality was just about in 4 patients as compared to about 19 patients into a group where 10-day. But mind you, into the group where you were moderately ill patients, that was taken into considerations. And even when Robert also shown that if you really see into the group that the death rate was maximum into the group where initially 5 days was used, but that was also into the group where invasive mechanical ventilation was used, or those patients who just require non-invasive, or those patients who also require only just oxygen kind of therapy. The recovery was also much better into the group where remdesivir was given for 5 days as compared to the group where it was given for 10 days. Currently into a review paper, which I was one of the leading authors to publish it into the Indian Journal of Critical Care Medicine, along with other stalwarts who are different COVID authorities into different parts of the country in India, and they're also the nodal officers for different parts of the state in India. We also compare different drugs, and from our paper in which was published just last month in IGCCM, we recommended that remdesivir should be used initiated early in the disease course in moderate and severe kind of patients, and those patients who require oxygen therapy and those patients who start needing non-invasive mechanical ventilation. Mind you, the selection of the patient and initiation has to be very early. That's the bottom line. That's most important. The pharmacodynamics and kinetics of COVID infections is mainly characterized by initially there is a high amount of a viral load. This viral load is very important, and targeting this viral load or reduction in this viral load is the key. And therefore, initiation of remdesivir early during the course in the first several days of infection, it significantly has a rapid delay period, and this rapid delay period is then followed by a slow clearance phase for the variable amount of duration till the final viral elimination phase, which may occur almost up to a date of 28 days, or sometimes even a delayed excretion into the fecal matter has been known up to 37 days. But more important for us is the initial hit hard. Even the clearance of the viral rate has to be reduced initially. The viral clearance rate has to be slowed down, and once the viral load decreases below a threshold of 10 raised to 5 RNA copies, then definitely you will avoid further complications of cytokine storm also. So initially, the first 5 days is most important for initiation and selection of these patients. The late expanders into the T cell responses is predicted to induce the eradication of the infected cells into the upper airways almost about 2 to 20 days later, and the timing of this final response appears to be variable amongst the infected kind of people. The pharmacokinetics in both these cases, that is at the day 10 of infections when severely infected people often seek hospitalization, or at day 5 when the infection immediately seek after viral peak or mainly occurs, and when infected they almost become asymptomatic, remdesivir impotently was assumed to be high, and the viral elimination occurred rapidly after initiation of therapy, especially when they were initiated early. And this effect occurred because of unopposed removal of approximately almost 100 to 1000 cells per day by ongoing innate immune response. So the innate immune response is also important, and that's how the viral clearance occurs. So initiation of early and initiation of reduction in the initial viral load plays a very important role as far as the action is concerned. As we know that it has got a very potent poor hepatic stability and results in almost a complete first pass effect clearance, and hence it cannot be given orally. You have to give it as a part of a loading dose of 200 milligrams of IV infusion into healthy subjects and the major circulated metabolite, and it has a half-life of about 69 minutes, and more importantly it has got a moderate protein binding into all the species, and good amount of volume distribution mainly occurs with predominant amount of concentrations into the lungs as into the respiratory tract. And following a single dose, we found that at doses ranging from 3 to 225 milligrams, remdesivir exhibited a very pharmacokinetic profile which was very linear. After even a single dose of 2-hour IV administration of approximately 75 to 150 milligrams of lyophilized solution, we also found a comparable amount of pharmacokinetic parameters, they indicating a similar amount of a formulation perfusions, while a single intravenous dose was given to a total recovery period of dose of more than 92%, consisting of approximately 74% of which was recovered in the urine and feces respectively, and the majority of the remdesivir dose recovered in the urine was a metabolite, while 10% was only the remdesivir, saying that yes, it's a metabolite, and excretion mainly occurs by also the kidneys. And adverse reactions this mainly occurs in only a few, just about hyperglycemia was seen in very few percentage of people. I have not seen personally in my use that I've seen hyperglycemia. Yes, hepatic dysfunction in the form of increased serum SGOT, SGPT has been seen, and we definitely need to monitor the SGPT and the SGOT levels. I would definitely recommend that monitoring the SGPT levels at the time of initiation of remdesivir, and on day 3 of remdesivir, and day 5 of remdesivir, and even after day 7 of remdesivir, definitely it needs to be seen. Recently, we have also seen few patients who have been received remdesivir have been getting mild SGOT, SGPT increases almost about 5 days after the duration of remdesivir is over, but they have been settling down in the next couple of days. So definitely you need to monitor the SGOT, SGPT levels at least on one day 3, 5, 7 on whenever the patients are on remdesivir. Acute renal failure is yes, but especially to where there is a decreased amount of GFR, there is increased serum creatinine, and as I told you mainly at the start, the cyclodextrin is the one which is component, and this may accumulate into these patients of renal into kidney patients, and they are the ones which increase the renal toxicity. Some patients may get fever, some patients that's mainly related to the infusion related problems, or certain if the infusion goes fast, therefore hypotension, nausea may occur, or certain people may get diaphoresis or shivering, but that's the reason why you need to give it slowly over a part of 1 hour, or even about 60 minutes, 70 minutes as a part of infusion with the help of syringe pump, and these will not occur. But mind you, yes, it's quite well tolerated, not much amount of problems if you use it very judiciously, and if the delivery of the drug is quite well done, then definitely we have not seen much amount of problems. The metabolic chloroquine, there have been certain drug interactions. Mind you, chloroquine may diminish the therapeutic effect of remdesivir, while even hydroxychloroquine may also diminish the therapeutic effect of remdesivir, and especially if the patient is being shifted from any other oral antivirals like favipiravir to remdesivir. Mind you, you should supposed to stop it and then move the patient onto remdesivir plus. And contraindications, not much, only if the patient has got renal failure or severe amount of hypersensitivity which is being there to the component formulation as per the FDA. The doses, as we discussed, and even Robert was quite well, that especially into those patients who have got a good amount of clearance, if you have got a normal serum creatinine, there is not much amount of dose adjustments which are really required into these patients. But those patients who have got a decreased amount of a GSR, you are supposed to avoid use of into it, or even to those patients where dialysis is there, because of the cyclodextrin component which may accumulate into the kidneys, which may worsen the renal impairment. Or in those patients who have got renal replacement therapy, you should avoid the use in those patients who have got renal replacement, whether their patients are on hemodialysis or peritoneal dialysis or even into CRRT, is also because of the cyclodextrin component, which may impair the renal functions. So the dosing in hepatic renal failure not recommended to be used, especially if the HGOT, HGPT levels are definitely a cirrhotic patients which have got a large amount of increased HGOT, HGPT, or there is fulminant hepatitis which is already there. And hepatotoxicity during therapy, especially is a concern, especially if the HGOT, HGPT values definitely go more than 5 times the baseline values. And therefore, I always recommend that it should monitor it with the help of HGOT, HGPT, and the LFTs at the baseline day before initiation, then on day 3, day 5, and even on day 7 after the remdesivir has been over. And it usually comes with no signs and symptoms. There could also be just increase in alkaline phosphatase, and in case there is a severe increase or more than 5 times or 6 times increase, then only FDA has recommended that there has to be a discontinuation of remdesivir, which is there. But clinically, we have not seen much amount of problem, especially if you judiciously and properly and in the right selection of the patient. The news in India, yes, it's a very novel antiviral which is being approved for use by the ICMR. Soon after the launch, also last month, antiretroviral agents, it has been used judiciously, very successfully, also used by intensivists all across the country in multiple hospitals in India. And they have also tried it where a combination of remdesivir along with dexamethasone and enoxaparin for patients with comorbidities. Mind you, all these patients who are especially the senior above the age of 60 patients, those patients who have got diabetes, those patients hypertensive, those patients where they have got, yes, it definitely proven beyond doubt and also been shown by various postmortem studies coming up from Italy that there is a microthrombotic disease which is occurring underlying into these patients of COVID. And these patients where there is definitely increased incidences of microthrombotic disorders, all these patients who are into the high risk category of diabetes, blood pressure, increased D-dimer levels, increased CRP levels, definitely should be kept on to low molecular weight heparins, or those patients who are ventilated. The fast track policies also need to be continued. These patients also need to be fed. These patients, the basic critical care cannot be compromised for any patients, even if you are using remdesivir, mind you, do not compromise the basics of critical care. Low molecular weight prophylaxis need to be given for all and each and every patients who are into the intensive care unit. And the news in India, yes, it has been approved as an experimental drug, not only in India but also all across the world, and now it has been approved in India by the ICMR, where initially it was not been approved. As I told you, it was only a part of the solidarity trial, but now after all these, now it has been approved. And even abroad there have been various incidences. Now it's been approved as a part, and now it's also become as a part of protocol. Even the Ministry of Health and even different governments of different state governments have also approved remdesivir and recommended remdesivir into the category of moderate to severe patients who are hypoxemic, those who require oxygen therapy, and those patients, mind you, have got pneumonia. That's very important. The hospital where I worked, we have initially was a COVID care center. We have now for the last 2 months have admitted more than a huge number of patients, but mainly the serious patients which were there more than 150, about 125, out of which since we started using remdesivir were about 25 patients. And at this minute of time while I'm talking, I've got 11 patients who are hypoxemic who are on remdesivir, which I have not included here. All these patients really included remdesivir. All these patients underwent a CT scan and the severity scores ranged from 6 to 21. We did have to use itolizumab and tocilizumab into 3 patients, where 2 patients received itolizumab and 1 patient received tocilizumab. 8 patients required non-invasive mechanical ventilations. The remaining patients, almost 17, required oxygen about 5 to 6 liters. The mortality was 1 only because of ventricular arrhythmias, and just day before your step mortality we had a second death, and that was also a senior citizen who died massively again because of acute myocardial infarctions on day 8. After completion of remdesivir therapy on day 5, he died because of a hyperacute anterior wall myocardial infarctions. Out of the 25 patients, I told you the survival was almost 25. These patients were sick. They were admitted to the intensive care unit. They required oxygen. They also required high flow. They required non-invasive mechanical ventilation. My experiences has been that those patients who have been onto oxygen where remdesivir was started, yes, the average duration of stay was just about 7 days, or in those patients who required NIV or high flow, the average duration of stay after treatment of remdesivir. This has not been analyzed data. These are just the not a validated data. These are pure data which I've just gathered for today's talks, and the recovery time was just about time of discharge was about 12 days into these patients who required non-invasive mechanical ventilation or high flow nasal oxygen. These are some of the scans which I've done into pre-treatment where remdesivir was started, where the severity score was quite severe enough, and this is the pre-discharge scans which was also done. And therefore my recommendation and also the observation that yes, as per the studies which we have also seen, and also from the Lancet NEGM studies, and also the IGCCM paper, that early use of remdesivir definitely helps us to de-escalate the patient and taper the patients who require oxygen as early as third day to the fourth day of treatment of remdesivir, or those patients who require non-invasive mechanical ventilations, they also get de-escalated onto those who require onto the mass oxygen. Definitely these certain patients may require oxygen. For these patients who require ventilation, they require oxygen for a certain pretty long period of time. And the best way to predict the future is to create it. And therefore we need to select the patients very accurately. We need to initiate remdesivir very accurately. We need to initiate it early in the course of therapy, as backed up by the current approaches, COVID therapy, as this paper published in IGCCM. And therefore, selection of the patient is very important. Initiate early in the course of therapy so as to have better outcomes. And these definitely initiating of this therapy initially into the right patients at the right timing is the real crux of initiation and the use of remdesivir in moderate to severe patients, or those who have got COVID pneumonias, and those who have been shown a severity score documented by lesions onto the CT scan, which has been done by a COVID protocol. In the end, I would like to thank my team and also thank Jubilant for inviting me for today's talk. These are few pictures where the team really works hard to come get these patients off on awake-prone ventilations, and I thank them all, and also thank all my staff, and thank you all for a very patient hearing.
Thanks a lot, Dr. Dixit. I think that was truly insightful, and especially in Indian context. We have a lot of questions out here, and given that it's an audience which has seen both cases from the West and situations from West and this part of the country, I think we'll try and do justice to most of these questions. But I'll start with the first question. So usually remdesivir is given in moderate to severe cases, but in patients with comorbid conditions, especially diabetes and CKD, can we give it earlier for favorable outcomes, and what would be these clinical criteria?
See, honestly, you need to have, as I told you, and even when Robert said that there has to be a documented form of pneumonia, especially when initiation of remdesivir is concerned. The patient must require oxygen therapy, which is there, or the patient may require a need certain form of ventilation. Just having a CKD patients who are just coming, and especially in renal failure patients, as we know that because of the cyclodextrin component, it's very dangerous to use it because there may be a worsening of amount of a renal failure, which could also be precipitated with the use of remdesivir. I mind you, especially use it in mild patients. Mind you, the milder variety of patients definitely are the ones who may recover on their own. And as I told you, the maximum amount of penetration is best seen and the concentration is best seen, especially into the lungs or into the respiratory tract. And therefore, those patients who have got COVID pneumonias documented on the X-ray or with the help of a CT scan, having a severity score. I used it in a severity score of more than 6 to 21. The latest patients, what I have is a very severe severity score of 4 just now, which is maximum out of 25. So this patient is also doing well. He just received the third day of remdesivir today, but he is holding on quite well. So in mild patients, they may recover on their own just by simple azithromycin or possibly with HCQS also. So you should have And especially with renal failure, it's a very difficult drug to use.
Okay. Given that we have seen context of two different scenarios and presentations here, any differences that you have seen in Indian patients versus the data reported from the West based on your experience?
Not much amount of data experience. We have been honestly following the data and the trials which have come up from the West. We still need to have a major Indian trial which should be erected and which should come out on the use of remdesivir. The data what I showed was a personal data which was just collected for the part of this talk, and as a part of my knowledge gathering, I collected the data for the last 1 month. So as and when we collect more and more data and analyze more and more data, definitely it will be a really good eye opener. But from the practical experiences what we have seen, yes, it helps and it definitely works, especially if initiated early. And in the selection of the patient is very important, and the timing of initiation is very important. That's the bottom line. You should not initiate it late, especially when the patient is being intubated and ventilated after the onset of multiple organ failure. So it should be initiated early. That's the bottom line. Because yes, as we know that it reduces the viral load much more rapidly and effectively, and definitely it should be initiated. That's the reason why it should hit hard at the start at itself into these moderate patients.
Sure.
Not in just mild patients, or just patient coming in with fever who is getting admitted fever as a symptom. He's not a patient who should be given remdesivir.
Okay, we spoke about time and timing. So connecting with that, time to radiological improvement post remdesivir therapy.
See, I've seen remdesivir, definitely the radiological recovery is not with the help of, it will take definitely 6 weeks to occur. But the functional recovery from the respiratory system, what I've seen, yes, those patients who require oxygen, almost about 6 liters to 8 liters of oxygen, definitely got de-escalated after giving remdesivir. And my experience was after third day, the requirements of oxygen started following, and certain subset of patients after full 5 days of remdesivir therapy, certain patients I could take them off remdesivir, off oxygen also, and mobilize the patients out and move them into the mobilize them in the ward, or move them into out of the intensive care units or the critical care unit. So that's one. On those patients who are onto non-invasive or those who are onto high flow nasal oxygen, yes, these patients also could be de-escalated, not directly weaned off or removed from oxygen off oxygen. Yes, they definitely got weaned off just to mask with a venturi or onto plain nasal oxygen or nasal prongs. They definitely require different higher the severity score, where the lungs and were very grossly affected on a CT scan. These are the patients who could be weaned off and they required oxygen therapy for a certain period of time. Just recently, I had a patient who was discharged almost about after 21 days, who required to get off oxygen. But yes, he was initially on non-invasive, then came onto mask, then just came onto a nasal oxygen, and then just after day 21, 24, he could be discharged from the hospital. Now he's off oxygen home. So, but he could be de-escalated once he was given remdesivir for 5 days. So that's one important thing.
Great. So another question is, can we start
And
remdesivir?
compared to radiological recovery, yes, the radiological recovery will take almost about 6 weeks for resolution. Where recently we have seen that certain patients who are also coming in, day before yesterday also, there have been certain patients who reported to KM Hospital, Mumbai, like there's the incidences of pulmonary fibrosis may remain for in about certain subset of patients, but radiological resolution will take certain weeks, almost 6 weeks to have a complete normal X-ray, like any other patient of pneumonia also.
Okay.
Yeah.
The next question, can we start remdesivir when HRCT chest shows pneumonia and patient is hypoxic without waiting for COVID-19 report?
No. See, that's for a COVID-19 report. Yes, there have been certain incidences where we suspect that we have sent a swab, we have done a CT, where the swab report is awaited. And now when a swab report is awaited, then these are the, yes, the CT picture comes that it favors COVID pneumonia. Then yes, definitely the swab needs to be there, because you also need to submit a positive swab report also to ICMR. So that's what is equally important. Yes, there have been incidences where they say that this is a COVID report. Certain hospitals and certain people are following it, that this is a COVID report. If the score is suggestive of that, they have been initiating. But in my hospital, at least, we have not initiated without a COVID positive report.
Sure. The next question is whether we can give remdesivir to COVID-19 patients with mild urea elevation and elevation of creatine level.
It depends upon how much is the creatinine value which is elevated. That's one. If the creatinine value is possibly elevated, say on from day one, it was elevated to 1.5. If repeated, if it's purely a fever which has just produced a dehydration and just increased a mild amount of a pre-renal kind of azotemia, where giving IV fluids to the patient normalizes the creatinine on day 2 or day 3. And if the patient then subsequently needs remdesivir, yes, definitely it can be given. But if these patients' creatinine value is going up day by day, especially because of a diabetic nephropathy or those patients who have got a chronic renal failure, I would definitely be very skeptical in using it, especially if the creat clearance is below 30. So fluid optimization is also equally important into these patients. That's what I told you, do not compromise the basics of intensive care and the basics of critical care in the management of these moderate to severe critically ill patients. So these patients require ICU. You need to optimize. You need to give them deep vein thrombosis prophylaxis. You need to give them nutrition. You need to see that the patients are fluid optimized. All proper handling of critical care is equally important, where remdesivir is one drug management part of it, of the whole patient care.
Okay.
So collectively is going to produce good results and good outcomes and reduce the mortality.
Okay. Now, Dr. Dixit, I know you asked this question to Dr. Grossberg, and I will take this opportunity to ask the same question to you. There is a difference of mortality rates in India and Western countries. What, in your opinion, can be the reason?
See, my opinion is, one, we have learned lessons from the West. That's what is the first most important thing what I would gather. We had the first case which came to us on 19th of March. Until over a period of time, we were progressed and we reached up to the peak where we had data coming in from the West that yes, these drugs are working. There is a microthrombotic thrombotic complications which are occurring into these patients. So definitely the data and the experiences, initially we had the concepts, and even the Western people initially had the concept that all patients of COVID patients had to be intubated early in the course of disease, till the time when we had that yes, certain other papers came up from the West as far as the nomenclature of the lung injury to the H and the L type. We could also gather inferences of how oxygen therapy should be given into these patients. There were initially a big no for non-invasive ventilation. There was initially a big no for high frequency nasal oxygen and only intubation. And that was the one where, so till the time we had data coming up and the experiences coming from the West, the concepts change. Now we have got, yes, avoid intubation as far as possible or delay intubation as far as possible, give oxygen therapy, use awake prone as per the CARP protocol is concerned, give the patient non-invasive ventilation or high flow nasal oxygen, though it's a aerosol generated procedure, taking proper precautions in PPE, use low molecular weight heparins early in the course of disease in these patients who have got diabetes, blood pressure, or the increased D-dimer levels, and continue to use them because they are the ones which are producing other complications. So these are the lessons what we learned from old postmortem reports which came up from Italy. We also got the ventilation strategies and the oxygen therapy strategies came up. We also got various other drug knowledges which also came up into India. So these are the lessons which we did learn. We incorporated it and we practiced it and we are still following it. That's what is and the most important part is all the efforts taken by all the critical care nurses and the doctors into different parts of the country, spending time with the patients, teaching the patients awake prone, giving oxygen. That's what is the key, and that's the reason why we've been able to decrease the mortality into India. That's what I personally feel. That's my opinion.
Great. Our final question for today. Have you seen cases of relapse in your experience, and was remdesivir used in any of these patients?
No, at this minute of time, I've never seen any relapse, which is been occurred into my hospital at least. I've not seen any patient coming back again with a repeat COVID relapse again. Yes, we have been monitoring these patients where we have got antibody titers we are seeing, and these patients are generating antibodies. Yes, certain patients are not generating antibodies and they are slow responders, and patients are taking time almost up to 28 days for 28 days for generation of antibodies. Till recently, I was discussing with one of my pathologist friend in Pune, where he did a study in Bombay, where he found that at the end of this I have not seen. He found that at the end of 3.5 months, he did a study onto his own staff of a pathology lab, a corporate pathology lab, where his staff was affected, his antibodies were positive, and somehow his antibodies vanished after 3.5 months. So that was this is not a published literature. This is just a anecdotal experience, what I'm just sharing. But I have not seen any patient of relapse in my hospital or to my knowledge. Yes, I read it somewhere in Kerala where one patient came back with a relapse. That's what I just heard. One of the healthcare workers who's initially had just mild symptoms, and he went home and again came back with a more fulminant kind of rare lung infection. That's what I've just heard. But I need to no
Sure.
relapse in my practice at least.
Sure. Thank you so much, Dr. Dixit. That was truly an insightful session. On behalf of Jubilant, would like to thank you once again. Dr. Gulshan, over to you.
Thank you so much, Mr. Vikas. It's been an honor to be among such accomplished individuals and hold this webinar today. A sincere vote of thanks to Dr. Grossberg, Dr. Subhal Dixit, Mr. Jasdeep Sood, Mr. Vikas Bansi, all the Jubilant team members and the Spirant team members to make this a successful event today. Thank you, audience, and have a wonderful day ahead. Take care and stay safe.
Thank you very much.
Thank you.
Thank you.
Thank you so
Stay
much.
safe. Thank you
Thank
so
you.
much.
Stay safe. Yeah, thank you.
Thank you.
Thank you, doctor.